Good morning, everyone. At the outset, I would like to thank MIOM for giving me this wonderful opportunity. So, I'll be talking on keratoconus diagnosis and early screening. Can we still miss it? So, keratoconus is a progressive bilateral ectasia of the cornea, leading to cone-like steepening, leading to irregular astigmatism and visual distortion. Early detection can help in preserving the vision and also preventing the progression and thereby improving the quality of life, because misdiagnosis can lead to irreversible visual loss. The epidemiology is the prevalence is around 138 in 1 lakh individuals, but there are multiple studies done in different geographic population showing multiple prevalences. So it's said to be having higher incidence among the individuals of Asian descent from the Indian subcontinent, also in China and also Australia. Also, there is a higher incidence in the Middle East, particularly in Saudi Arabian adolescents, where it has reached 4,790 per 1 lakh individuals. This is a study done in different geographic locations showing different epidemiological factors. So true prevalence is basically it's underestimated. Now it's getting better. It's increasing with better diagnostics and awareness. So there was a study done in 2020 where 722 eyes were taken and the mean age of diagnosis was 24.7 years, and 1/3 of them had thinnest pachy less than 450 and the Kmax was 58.4. So even there are, despite of any advances in diagnostic tools, early keratoconus is still being missed. So genetics also plays a very important role, with the family history being very important, autosomal dominance with reduced penetrance being 90% of them, and also consanguinity plays a very important role. We need to take history of that. And there was another study, in CLEG study, where there was positive family history in 13.5%. Eye rubbing is also very important. We need to ask history of eye rubbing. So it can happen in genetically predisposed eye. These habits are very hard to break. So we need to counsel them thoroughly. And also if there are any signs of allergy, we need to control it. And there are also genetic conditions linked to keratoconus like atopic dermatitis, Down syndrome, floppy eyelid, obstructive sleep apnea. Also 34% of the people also have joint hypermobility. So we need to find all these red flags in the OPD itself. So the background is very important. So habitual eye rubbing, frequent change of glasses is something we need to ask for. Also history of any systemic conditions that I mentioned, and previous eye surgery like previous laser vision correction. So early symptoms are blurring of vision, intolerance to spectacle or contact lens, eye strain, headaches, eye irritation, redness and itching, which is again associated to allergy. Other symptoms are sensitivity to light, glare and halos around light, and also they complain of difficulty driving in the night. So the most basic thing that we have is a automated refractometer, the AR machine. So it can show errors. Again, we need to suspect when it shows any errors. High cylinder, steep keratometry, and also against the rule astigmatism. There was a study done using the AR machine which showed 41% of keratoconus patients showed against the rule astigmatism or oblique astigmatism, and none of them were correctable up to 6/6 or 20/20. So whenever these changes are there in the AR machine, so this is the indication to do a tomography scan. Also retinoscopy, we can see the scissoring reflex. It's a very sensitive and a reliable thing, and there's no need of any advanced equipment. We can check in the OPD itself with the basic setup, and it has a sensitivity of 98 and specificity of 78%. Again, in refraction, we find these patients are myopic with irregular astigmatism, and there is atypical increase in astigmatism in these patients, and there's difference of astigmatism in both the eyes. Again, there's loss of best corrected visual acuity, and the visual quality, which is very important, is reduced in these patients. So they never improve to 6/6 with full correction. Then in slit lamp examination, we find all the typical findings of keratoconus like the facial sling, walk striae, but in early cases, it can still be missed. So we need to do a thorough examination. And also do not forget to evert the lid in these cases, because there can be signs of allergy which we need to address immediately. So all these things that I mentioned, like the steep K, error in autorefractometer, cylinder more than -3, aggressive eye rubbing, abnormal reflex, family history. So all these things that give us clue to go for a scan. So there are multiple changes that come in pentacam, which is beyond the scope of this presentation. So keratoconus comes in different shapes and sizes. Like we have the round oval, then we have the superior steepening, inferior steepening, that's more commonly seen, asymmetric bow tie with skewed radial axis, and there are multiple parameters that we need to look in pentacam. Also, we shouldn't miss that there are many mimickers of keratoconus. So even in dry eye patients also, we need to be very make sure that it is treated, and then the scan should be repeated, because sometimes it can mimic keratoconus, and even in contact lens warpage. So we need to make sure the patient has discontinued contact lens when they come to you for a checkup, because that also can mimic keratoconus. And other conditions like Fuchs dystrophy, even history of refractive surgery is very important, and also measurement artifacts. And nowadays children has to be screened. They have to be taken extra care, because there's greater incidence nowadays in children, and the reason we have to take extra care is because they have poor prognosis, they progress very quickly, and even if we plan for a keratoplasty in advanced cases, a higher chance of rejection. So screening in children is very, very important. So earliest detection is the key. And then we have the subclinical or FF cases, that's a form first keratoconus, where the vision is normal, the slit lamp findings are normal, but there are some suspicious elevation in pentacam. So it's very crucial to detect this before we plan for any refractive surgery. So the pentacam might show some changes, so we need to evaluate them further. In form first keratoconus, one eye will have keratoconus where the other eye is normal, or we need to evaluate them further. So this is like a tip of the iceberg phenomenon where everything seems normal, but then comes the corneal biomechanics where we have to dwell further into. So these are the advanced screening parameters. So if we have access to it, we have to go ahead and further evaluate. So let me just talk about the Corvis. So Corvis also helps in knowing the biomechanical stability of the cornea. So before any refractive surgery or any screening, it's very important that we look into these parameters as well. That's the CBI, TBI and the BAD-D. So we can see in the image that is integrated with topography, and these things also has to be taken under consideration. And then we have the eye trace, where we can measure the aberrations in the cornea, the total aberrations as well as the internal aberrations. So this also helps in early screening of keratoconus. And if we have access to epithelial mapping, we need to look for something called as the donut sign. Here the epithelium over the area of protrusion is very thin and the surrounding epithelium seems thicker. So this is the donut sign, and it's one of the earliest screening parameter. Then we have the new frontiers like the genetic screening, where just a cheek swab is enough. The results come within a week. This is not going to give you a positive or a negative result, but it is going to give you a risk score for keratoconus. So it's very important that if somebody has keratoconus, you can screen the family members with this screening. And then now artificial AI, AI has come into picture. It's a newly added tool in detecting and diagnosing and categorizing keratoconus with new AI-driven algorithms. And then we have the Insta KC or the Smart KC. It's by Remedio, no financial interest, but it's a smartphone-based keratoconus screening, and it instantly captures images, and you can also connect it to your EMR. So the take-home message is that yes, it starts even before it's visible clinically. Early and accurate screening saves sight and thereby improving the quality of life. So we need to combine multimodal imaging technologies and never underestimate any borderline cornea. So we need to further evaluate or refer these cases and train the general ophthalmologist to read the maps better. Thank you.